thank you for joining us today for the Cancer Conversations, a community discussion on liver cancer awareness and prevention. I am Manala Badi. I'm a senior program coordinator with Mayo Clinic, Minnesota. And along with me is Chelsea Reeves, a senior program coordinator with Mayo Clinic, Florida. We are grateful that you're joining us today for this event, and we are excited to bring this valuable information to you. We would like to extend our gratitude to Dr. Lionel Kanku-Fonkwa and Mr. Derek Nelson, Mr. Quinn Goodman for collaborating with us on this Cancer Conversation event. Mayo Clinic's Cancer Conversation series is designed to bring physicians, researchers, and community members together to share and learn more about various types of cancer, their signs, symptoms, and treatments. These conversations are designed to educate and empower us to take our health journey into our own hands, get our screenings done, and take our health seriously. Today, we have an engaging program for you, so please feel free to take notes and put your questions in our chat. And we will have a presentation on liver cancer shortly by Dr. Lionel Kanku-Fonkwa, an assistant professor of oncology from Mayo Clinic, followed by a panel discussion from 2 liver cancer patients.
Great. So thank you, Manal, and the Mayo Clinic Community Outreach and Engagement Center for the invitation to talk to you today about liver cancer. Really, this is an important topic, and as Manal mentioned, I love to disseminate the information and help people prevent cancer, and if they do get cancer, know where to get the right information to get the best treatment. So I'm really delighted to be here today. As she mentioned, I'm Dr. Lionel Kanku-Fonkwa. I'm a medical oncologist here in Rochester, and I take care of patients with cancers of the GI tract and the liver, and that's also where I do a lot of my research. So happy to be here. So this is kind of the outline of my talk. Really, I know we have a broad, diverse audience, so I try to keep it basic, and but I'm happy to answer any specific questions that may not be covered here. But this is the outline, really talking about really what's the liver, starting there and why it's such an important organ. And then try to clarify or differentiate primary versus secondary liver cancer. And then going to how liver cancer arises, how common it is, how it's diagnosed and stage, and how it's treated. And then hopefully I will send you home with some pearls on how you can take action, hopefully from today. Starting with just what's the liver. The liver is that big, almost football size organ that's on the right side of your abdomen, your belly. It's really one of the largest organs in your body, and critical organ because it serves, it has over 500 functions. Really, we call it a detox center because it really clears up, filters your blood, and gets rid of toxins, and sends that filtered, hopefully clean blood back to the heart. So you can imagine how if it's not doing its job, not only the liver is affected, but a lot of organs like the heart, the kidney, and others, may not be able to function well. In addition to that, it also makes substances that you need to live, such as some proteins, good cholesterol, and that greenish fluid, the bile, that helps with the digestion of fats and stored in the gallbladder. So this is just to give you some orientation. Um, and I also want to differentiate primary versus secondary liver cancer. So one of the most common questions or, point of confusion is, someone has a liver mass and they automatically think they have liver cancer. And that's not always true. Actually, when you have a liver mass, it could be one of 3 things. It could be a metastasis, meaning cancer that spread from another organ like the colon or the lungs, to the liver. That's actually the most common scenario. You could have what we call intrahepatic cholangiocarcinoma, which is bile duct cancer, but just the portion of the bile duct that just happens to be in the liver, a mass grows out of it, so that's considered primary liver cancer. But the other type of primary liver cancer the more common type is hepatocellular carcinoma, and that's the type that actually arises from liver tissue. And that's the most common type of primary liver cancer, probably more than 80% of cases. And the other type is intrahepatic cholangiocarcinoma, approximately 15%. And as I mentioned earlier, the secondary metastatic liver, um, uh, the metastases are the most common scenario, but they're usually coming from elsewhere. So this is, again, just to orient you to make sure we, talking about the same thing here. So for the rest of the discussion, I'm going to be focusing on hepatocellular carcinoma. So this is the cancer that actually arises from the liver parenchyma, the liver tissue. Um, so so how does liver cancer develop? So if you take a normal healthy liver, usually, it would result, liver cancer will come from chronic inflammation to the liver. That's repeated damage to the liver from a variety of reasons, what we call hepatitis. Hepatitis means, itis means inflammation. So chronic inflammation of the liver. And that could be due to a number of reasons, and I'm putting them all here. The four major reasons or risk factors are listed here. Alcoholic liver disease can cause chronic damage to the liver. Hepatitis B and C viral infections can also cause damage to the liver. And then metabolic dysfunction associated steatohepatitis. This is just a fancy word for damage resulting from fatty liver disease. So those are kind of the four big risk factors for chronic hepatitis. Now, if you have chronic hepatitis for a long time, that chronic inflammation, you can imagine repeated damage to the liver. It's like if you burn your skin repeatedly, it heals, you burn it, it heals, you burn it. Eventually, it's going to change. And it becomes what we call nodular. You could see that. It's like having multiple scars on a tissue. And this is what we call cirrhosis. So over time, that chronic hepatitis will turn the liver into cirrhosis. And then if you have cirrhosis long enough, eventually you will develop a liver cancer. So that's kind of the pathogenesis of how liver cancer arises. One thing I want to mention here is that if you have a viral hepatitis B infection, you can actually skip the cirrhosis step. So that means you can have chronic hepatitis B and then go straight to liver cancer. So that's the one exception here. But for all the other risk factors, they typically follow this. So if you have, someone who has chronic hepatitis B, it's even more important for them to be to undergo surveillance and be vigilant, because they could literally go from chronic hepatitis to liver cancer. So, liver cirrhosis, as I mentioned, is kind of like the precancerous state. So you've had damage to your liver. It's not cancerous yet, but it's enough damage that, you're starting to experience signs and symptoms of severe liver disease. So this is one of the strongest risk factors for developing HCC. And it could be just as dangerous as cancer. If you know someone who has liver cirrhosis, even without liver cancer, their health is affected because the liver is unable to do all of the functions that I mentioned earlier. And so this is very, very, very serious. And like I mentioned, most people with cirrhosis have scar tissue because of that repeated chronic inflammation that ultimately blocks the flow of blood, through the main portal vein. That's that big vein that drains the liver. And, because of that, pressure builds up in this system, and then that blood backs up into some of the other veins. And you could see here into the esophagus, that's the food pipe, and even into the stomach. And we call them varices. If you've seen people with, large dilated veins in their legs, what we typically call varicose veins, it's the same process, but, in your um, upper digestive tract. So these veins are not as good as normal veins. They are very thin walled and they bleed easily and they can burst open easily. So you can see why one of the most common signs of cirrhosis is bleeding. Bleeding from the GI tract. So if one of these veins bursts and and you bleed, you're gonna have you may vomit blood, or you can actually have blood in your stool, usually melena, meaning that's dark blood, but because by the time it gets to your stools, is dark. You can also have, just like these veins, you can have hemorrhoidal veins. So veins or hemorrhoids, veins that are near your anal area that become dilated like this, and they can also bleed easily. So it's not uncommon for patients with cirrhosis to bleed from above, so here in the upper GI tract, but also from below. So you can either see dark melana, tarry looking stools, or bright red blood on your stool. So that's usually one of the common symptoms of cirrhosis, or a sign that maybe something is wrong with your liver. There are other symptoms that come with cirrhosis. Obviously, jaundice, because the liver is not doing its job of clearing up that bile, and when it backs up into your blood, you can have yellowing of your skin, of your eyes. But I think I'll get into that in a second. But that's also a result of cirrhosis. And how do we grade the severity of cirrhosis? There's this scoring system called the Child-Pugh score, and I'm not going to get into the intricacies of it, but literally we have three classes: A, B, and C. A means it's mild, B moderate, and C severe. When you have severe liver disease, so Child-Pugh C, that's usually an end stage liver disease. You're not able to process, certain medications. Your liver is not healthy to do a lot of things, and usually that's an end stage liver disease. And so you can imagine having cirrhosis, that's already one liver disease, and then you add on top of that liver cancer. It's almost like a double hit. So that's why it's very important to prevent the cirrhosis, and when it happens, try to control it. So some of the risk factors for cirrhosis and or liver cancer, I think I mentioned a few of them already. Hepatitis, viral hepatitis, B and C. Fatty liver disease, so non-alcoholic fatty liver disease, diabetes. Again, the reason why is because your body is having a hard time breaking down sugar, which means that fat can build up in the liver. So both of them are part of what we call metabolic syndrome. Drinking a lot of alcohol, obviously, can damage your liver. And then, depending on what part of the world you're in Asia and Africa, there's this aflatoxin fungus that can infect your liver and cause cirrhosis and or liver cancer. More rare, but also a possibility is hereditary diseases due to genetic mutations. And the two classic examples are hemochromatosis, which is a disease in which your body is not able to is storing excess iron, and a lot of that iron is deposited in your liver and causes liver damage. And then Wilson's disease is the same process but with copper, where you have depositing a lot of copper in different organs, your eyes, your liver, and that could also cause liver cancer. So those are rarer but still possibilities. And now also obviously autoimmune disease or any problems with the heart. Because again, that crosstalk, that communication between the liver and the heart. So this is in general, if someone has liver cancer, they will fit into one of these categories. So how common is liver cancer? Liver cancer, is the sixth most common cancer worldwide and the second leading cause of cancer-related deaths. And I'm putting this map here to show that really it's not a one-size-fits-all, meaning the etiology, the cause of the liver cancer really varies depending on what part of the world you're in. You will see that in, Asia, Southeast Asia, and Sub-Saharan Africa, hepatitis B is the main driver. Whereas in the West, you have a mixture of alcohol, hepatitis C. So really where you're coming from, your origin, can lead to a certain type of risk factor that leads to cirrhosis and eventually to liver cancer. And that's very important because, we treat these patients all the same in clinic, but we're noticing that they respond differently to different treatments depending on what was the original cause of the liver cancer. So this is it again is very important for us to really pay attention to that as clinicians in the clinic, but also even in our studies to make sure that we diversify our studies to represent all these different etiologies. Otherwise, we may take one treatment and assume that it's going to work the same in all patients. And so that's what I'm highlighting here, that HBV infection accounts for about 60% of cases in Asia and Africa, whereas in the West, it's kind of a mixture of alcohol, hepatitis C, and fatty liver disease. And more than the 2/3 of patients at diagnosis are not candidates for curative treatment options. Again, we'll talk about that later, and such that the overall survival, the 5-year overall survival is dismal at less than 20%. So, liver cancer is projected to be the third. I think I said it was the sixth most common cause of cancer, but it's projected to be the third leading cause of cancer-related deaths in the US by 2035. You could see the graphs here. And just for this year, this coming year, it is estimated that you will have about 42,000 new diagnoses, 80% of them being HCC, and about 30,000 deaths just this year from liver cancer. So this is a rising problem that we need to really pay attention to. So globally and nationally in the US, you can kind of see the breakdown in terms of the incidence by race and ethnicity. Again, you could see here that racial, ethnic minorities disproportionately shoulder the burden of not just from incidence and mortality, with the American Indian, Alaskan Natives leading the way, followed by Hispanics, Asian Pacific Islanders, and Blacks. Again, these are national trends, national data. Now, when you look closely I'm in Rochester, Minnesota, so I'm going to use this as an example, but I'm sure if you do this exercise in different states, Texas, California, Arizona, you kind of see the same trends that, Blacks, and again, these racial ethnic minorities are disproportionately shouldering the burden, but you could see here that Blacks are leading the way. Along with American Indians and Asian Pacific Islanders, compared to their white counterpart. You could see the incidents are almost 5 times that of their white counterpart for Black people. So it is the devil's always in the details. So they are national trends, but I encourage you guys in your area to look at specifically what the trends are. And here in Minnesota, I mentioned viral hepatitis being one of the risk factors. So you also see here that for chronic hepatitis B and chronic hepatitis B, it's not surprising that those same groups, those racial ethnic minorities, are also leading the way in terms of incidence. So it's not surprising. A particular group that we have, particular patient population that we have here is the Somali immigrant population. And this is a study that was done over a decade ago by Dr. Shar, but showed that here in Minnesota, the incidence of chronic hepatitis B was tenfold higher in Somalis compared to non-Somalis. For hepatitis C, threefold higher in Somalis compared to non-Somalis. And it's not surprising that the liver cancer incidence, among Black Minnesotans is almost 5-fold higher than that of white. Again, this is probably contributing to that. So you could see a direct cause and effect here. So emphasizing the importance of really screening and putting this at-risk patient population in a screening pipeline and early intervention pipeline. So this is the cancer disparities report from AACR, the American Institute of Cancer Research, from last year. And you could see here when they look at beyond just the global trends, they look at really the disparities and at-risk patient populations. You could see here that immigrants, refugees, and asylum seekers are 78% more than likely of getting cancer. And we highlighted here that patient population that I mentioned here in Olmsted County, the Somali immigrant population being at 5 times higher risk of getting liver cancer compared to non-Somali. So again, you could see here that yes, there are global trends, but when you look at the detail, there are specific at-risk populations that we need to particularly pay attention to. Otherwise, we're going to be continue to widen the disparities and the gaps between in outcomes. So I'm just highlighting here some of the examples of, what I'm an oncologist, so I see a lot of these patients at the end of the road, and I always wish we could have done a lot earlier. So culturally tailored community outreach and engagement, this is just an example with this Somali population that we've identified here as being high risk for this, to try to intervene earlier and hopefully cure some of these patients, if not help them get treatment and live a meaningful life. So, how is liver cancer diagnosed? So, the problem is a lot of people don't have symptoms until the cancer is advanced, and that's why it's very important to be screened. If it's been determined that you are an at-risk patient population, you have some of these risk factors that I talked about earlier. You should be in a screening pipeline, regular screening pipeline. But some of the symptoms that you may see sometimes at a later stage range from pain or swelling in the stomach area, nausea, vomiting, loss of appetite, and as a result of all of this, losing weight without unintentional weight loss. Tired, feeling fatigue, like I mentioned, the liver cleans, it's a detox center, but also helps make a lot of protein. So if it's not working well and you're not eating, you're losing weight, you're definitely going to feel fatigue. Jaundice, that's that yellowing of the skin and white of the eyes, the sclera. And that's because that bile, that green fluid that is supposed to be, processed and drained, it's not being drained and backs up into the blood and causes jaundice. Some patients could get anemia, so low blood count, easy bruising because their platelet is not functioning well, or they have a lower amount of them. And then heals that are wounds that are not that don't heal properly. Again, because some of the proteins that you need, some of the factors that you need to heal, are not being made by the liver. And a lot of them will have kind of low-grade fevers and night sweats, and then a darker urine. And in the urine that's dark is again because that bilirubin, that bile is not being cleared. So you're seeing breakdowns of that into the urine. So dark urine, yellowing of your skin is usually a sign, or even stool that are clay colored. Those are all signs that that something is not right in your liver. And in terms of testing, there are a number of tests that could be done. Usually starting with just regular blood counts. So looking at your red blood cells, your platelet count, your white blood cells. Those are the infection fighting cells. And then looking into liver function tests. And there are a number of tests to assess the liver function. Bilirubin, again, that's that breakdown from bile. If it's high in your blood, that tells us something is not right in your liver, and pretty soon you may already be or will be jaundice and have that yellowing. Albumin, that's another protein that's very important. If it's low, that makes us think that maybe your liver is not functioning well because it's not synthesizing this protein. Your platelet count, if it's low, that's usually a sign that you have pretty bad cirrhosis. And as a result of that, your platelet are being chewed up or congested in the spleen, and that's not an uncommon finding that you have low platelet count. So that could cause easy bruising or easy bleeding. And then some of your blood, we typically see that your blood is too thin, and we have blood clotting tests that we can do. And if your blood is too thin, that puts you at a higher risk of bleeding. So that's usually basic blood work that we can do that will tell us that something is not right in your liver. Your liver is not functioning well. Now, there's another test called, it's a protein called alpha fetoprotein. We call that cancer. It's a cancer or tumor marker. That may also be a sign if we see that marker is elevated. That could also support the suspicion that you likely have liver cancer. It's not always the case. So there are cases of patients with normal AFP that have liver cancer, but I would probably say about 75% of patients with liver cancer would have a high AFP level. So if you're seeing something that's not fitting right, that test is also elevated, that just increases that probability that you likely have liver cancer. So once that initial suspicion is established, whether it be a combination of your symptoms and some of the initial blood work, then the next step is really get imaging study. So try to look for assess the liver, and that could happen in a variety of ways. The cheapest and easiest way is an ultrasound. Just put an ultrasound probe around the liver, around your belly, to see if everything looks okay. And based on that, you can at least determine, are we dealing with cirrhosis? Is there a mass? Is that something abnormal? And then from there, you could go to get a CAT scan, a regular CAT scan, which is a more involved scan, or an MRI, depending on what the ultrasound finding showed. Um, and then if we see something there, usually we'll even get a CAT scan of your chest to see if there's spread of the tumors outside of the liver, like in the lungs, for example. And then, another way to diagnose is get a biopsy. where we get a piece of tissue, usually through an ultrasound guided procedure, and then we send that tissue back to the laboratory to see if we are, the cells in the mass that was sampled are cancerous. But I would say liver cancer is one of those cancers that you actually don't need a biopsy to diagnose. So with just a CT scan or an MRI, you can actually diagnose liver cancer. And I think I have a slide on that later. Now we do biopsies because we're able to do genetic testing with the biopsy material. But in resource poor settings, you could diagnose a liver cancer with just a scan. You actually don't need a biopsy. And so I mentioned screening earlier and how important that is. And for someone who's been identified as someone at risk of liver cancer, the standard of care screening is every 6 months ultrasound and AFP. So AFP is that protein that I said in about 75 to 80% of patients with liver cancer is going to be high. So there's studies that have shown that if you combine that blood test with this ultrasound every 6 months, patients who are at risk of liver cancer, that means patients who have cirrhosis or chronic hepatitis B, for example, you have a high chance of detecting the cancer early on if it shows up. And this is just an algorithm that us clinicians use to kind of, determine what to do. But in a nutshell, uh, every patient who's at risk should get an ultrasound and an AFP every 6 months. And based on the findings, that could trigger us to get more involved testing like an MRI or even a biopsy sometimes. But unfortunately, the majority of patients are not getting screened because this screening is underutilized. And I'll show that some data on that later. And unfortunately, that means that up to 50% of patients are diagnosed at a later stage, either intermediate or advanced stage, because they're not being screened appropriately. And that could mean missing an opportunity to be cured from this cancer. So this is the data again showing underutilization of screening. This is a study that was done here in Minnesota, a cohort of about almost 400 patients, with cirrhosis, and you see here that for a test that is approved and standard of care, only 14% of patients got the recommended uninterrupted surveillance every 6 months. So these are patients who are at risk of getting liver cancer. There is a test that's recommended, but only 14% of them are getting it. And a lot of them actually were because they ended up seeing hepatologists. So this is, the specialists, GIH, gastroenterology, and hepatologists. Those were the people who actually, their patients were actually the ones getting it regularly. But you could see that, so there's a problem both at the primary care level, but also at the, maybe at the patient level, because some of these patients probably were not adherent to the screening. So we need to improve, this, because 14% for something that's available and that could prevent, that could lead to early identification of the cancer. It's a very low rate. And this is in Minnesota, but it's across the board. If you look at different studies across the nation, it's in the 15 to 20% rate. So that's part of the problem. And a lot of these is, unfortunately, in minorities, racial ethnic minorities that are in underserved, underinsured situations. And again, this is what creates and widens the disparities. And I'm showing this data to say not only do we need to screen, but there are particular populations. Here I'm highlighting those of African Black race, but also birth in Africa. This is a study that showed that patients of Black race and birth in Africa, except for North Africa, have a strong risk of getting very early onset HCC. So if you're from African descent and you were born in Africa, your risk goes even higher, meaning earlier onset, less than 40 years old. So you can imagine, so that gives us even another reason to really design comprehensive surveillance programs to really intercept this disease early on. So I mentioned that you can diagnose HCC really just based on with a scan, a CAT scan or an MRI. And there are if there are clinicians in the audience, you may have seen on the radiology report the LIRADS classification. The radiologist, just based on the scan, can determine the probability of it being liver cancer. You see here LIRADS 5 or LR5, that's a 95% chance that you have HCC. And we see that, we stop there, we don't even need a biopsy. Now, some may be at LIRADS 3, meaning 20 to 40%, but that doesn't mean that this LIRADS 3 lesion doesn't have the ability to progress to LIRADS 5. So if you see LIRADS 3, that means you need to probably screen them or monitor them more vigilantly, because there's a possibility that they will progress to LIRADS 4 and eventually to LIRADS 5. And there are other categories, but the point here is to say, just based on the scan, CT or MRI, we can actually diagnose this disease. And this is the reason why we can diagnose this disease, that LIRADS classification, the liver reporting and data system. When we give you a CAT scan or with contrast, HCC, this disease, which is a very vascular disease that relies heavily on blood supply, tends to enhance on the arterial phase of that CAT scan, and then that enhancement washes out, as you can see here, on the venous phase. So that's why when we see this is classic pathognomonic, slam dunk HCC. You see that pattern of enhancement and washout, this is HCC. Now, sometimes it's not always like that, and that's where we have to follow them more vigilantly and sometimes biopsy. But in general, using these criteria, which are well validated, we can diagnose patients with just a scan. So now, once you've diagnosed them, how do you stage them? I think in general, the diagram on the left really just shows you that in general, the most common categories are: is this a precancerous lesion, like I told you on that LIRADS 3 that could progress to LIRADS 5? Is this just localized to the liver, meaning you have one lesion? Is it locally advanced, meaning it started to spread a little bit, maybe to the blood vessels? Is it like late locally advanced, meaning some of the surrounding organs maybe? Has it metastasized? Has it spread beyond the liver? So this is in general, when you speak to patients, this is how we describe this. But if you look at a more granular level for HCC specifically, these are all the stages here, and with what they look like, ranging from very early with just one tumor that's less than 2 centimeters to early where you can have 3 tumors or one single tumor that's less than 5 centimeters, or 3 tumors that are each less than 3 centimeters. An intermediate stage where you have multiple, tumors on both sides of the liver. A more advanced stage where now the tumor has started to spread into the blood vessels or has actually spread outside of the liver. And then the later stage is when, remember I told you, a patient with liver cancer and cirrhosis actually has 2 diseases. He's fighting the cirrhosis, which is a bad disease, and then on top of that, you add the cancer. And those patients in the stage D, usually we can't even treat them because the liver is not even healthy enough to receive treatment, because the liver cannot process the cancer treatment. So those patients usually, we just do palliative or best supportive care, because treatment can actually harm them. And so my hope is to prevent, seeing patients at this stage, because we're doing the right screening, we could catch them early on here and actually cure them from the disease. Because when I see patients here, there's not much I could do. And that's part of the reason why I'm doing a lot of the outreach that I do, because I want to see more patients here when we can actually do something. And when you meet patients, you read about, their course, you realize there were so many opportunities, even from earlier on when they had just hepatitis, where they could have been plugged into a screening program. And if they were followed, surveilled appropriately, could have been caught when they only had, 1 or 2 tumors, and could have been cured. But when you see someone here, at this late stage, there's not much you could do. So it's very important, really, to be proactive. So I have a little video here to show you a little bit how this liver cancer, and cancers in general, but even more so, this liver cancer can progress, starting with just a mutation in one of the cells that will eventually, spread using the blood supply. So maybe I'll play that. Hopefully we don't have any technical challenges, and hopefully you're able to see, and let me know if you're not. But you start here with a mutant cell, right? Now that cell's now splits, starts to divide, progressively, probably grows into a mass because you have more cells. And then at some point, it's going to recruit blood vessels. You see how it's going to grow into a mass here. So it's growing, and as it grows, it's going to need, this is still the precancerous stage. It's going to recruit blood vessels to feed the tumor. And HCC loves to do that. It relies heavily on blood supply. And you could see this is a process called angiogenesis. And you can see how it's growing. It's going to continue to grow, relying on the blood supply. And then that same blood supply is going to help spread. Those cells are going to infiltrate the blood supply and then start to spread. You see the green cell there is the metastasis. It's going to spread and then go to other organs. So again, and once that spread has happened, you can go and cut what you see in the liver, but it's sometimes too late because the cells are already out there. So this is why it's very important to catch this very early and give you the best shot at being cured. So how is it treated? I could give a master class on treatment for HCC. It will probably take 2 hours, but I'm just going to highlight give you a high level overview. And if there are questions specific to treatments, I'm happy to answer them later. But again, if you start with the different stages, the treatment is guided by the stage. And the earlier the stage is, the more available, there are more curative options available. So if you have 1 or 2 lesions here, then usually ablation, which is just heat energy, so burning that tumor with heat energy, or surgery, cutting it out, is an option. Now, if it's more advanced, meaning it's in different places, it's a little bigger, there's maybe invasion into the blood vessels, then we use intra-arterial therapies, again, because it relies heavily on the blood supply. We have to, we direct it towards the blood supply, we shrink the blood supply. And then radiation therapy, where we can burn some of the lesions. And then in advanced stage, there's also transplant. That's also available for patients that are eligible. And in the more advanced stages, there's novel therapies called immunotherapy, which has really changed the game for this cancer. So this is a type of therapy that's designed to boost your immune system to attack the cancer. When it works well, it's like being vaccinated against a cancer. Your immune system is doing now what it was meant to do. It could work well and has changed the lives of a lot of patients with liver cancer that are now living beyond, what we were accustomed to. And then targeted therapy, targeting different processes that are helping grow the tumor. And then obviously clinical trials across the spectrum. That's the way you move the needle forward. How is the way you improve upon the standard of care? So you can imagine if you catch a patient here, he doesn't have the opportunity to get all of these. And so it's very important to be detected early. And you could see here, the earlier you detect it, the longer your survival. So again, but the screening tests are not really being utilized. I put this here to say that, it's very important. This can get complex. So if you have a patient who gets diagnosed with liver cancer, it's very important to refer them to a tertiary care center or a center that has expertise, because this data that I showed you with the survival could be doubled if you have a personalized approach using different specialties. We call that multidisciplinary treatment, where you have the hepatologist, the oncologist, the transplant people, the surgeons, all working on your case to figure out what is the best treatment for you. The box here in red shows you that you can double and sometimes triples the outcomes of survival if you use a more personalized approach. So I put this here to say there's so much you could do, so many directions we could go with your treatment, but that's determined by a multidisciplinary approach. So that's very important. Again, this is what I'm emphasizing here. So multidisciplinary care improves early detection, treatment, time to treatment, the chance of getting a curative treatment, and then survival. So what are some steps you can take? I think get screened, obviously. You have to know the facts. So that's part of this. If you're not aware, you're not going to know what to do. So know the fact, be proactive about your health, and get screened. So get screened for viral hepatitis B. There's a cure for viral hepatitis C. There's a vaccine to prevent viral hepatitis B, and there's treatment for viral hepatitis B. So you could see early on, if you know what's going on, you can actually prevent progression to cirrhosis and liver cancer. Diet and obesity. So these are lifestyle changes. I told you fatty liver disease, metabolic syndrome can cause a liver cancer. So watching what you eat, exercising regularly, more fruits, vegetables, limiting alcohol intake. And I put here what that means for men and women. Smoking, smoking tobacco is a class 1 carcinogen across the board, not just in liver cancer. Needle sharing, because that's how a lot of people can get hepatitis. And then get screened. If you determine that you're at risk, get screened because early detection can lead to cure. And the screening right now is with liver ultrasound and this cancer marker AFP every 6 months. So I hope with all of that you don't get cancer, and if you get it, it's very important for you to not lose hope, because I know patients who live meaningful lives even after the cancer diagnosis. The key is finding the right team, and like I mentioned, today you have to be seen, at least get an opinion at a tertiary care center, because the treatment is very complex. I'm just highlighting here our team here. That's the dedicated team that takes care of liver patients with liver cancer. But anywhere you are in Arizona, Florida, they're probably tertiary care centers that you can reach out to at least get an opinion, a second opinion about how to manage your cancer. And I'm going to end here with this quote from Stuart Scott. Some of you may know him. He was an ESPN sportscaster that died of pancreatic cancer. But this quote really lives with me, because he says, you beat cancer by how you live, why you live, and then the manner in which you live. So you can beat this cancer if you live the right way. I talked about some of the lifestyle changes you could do, prevention, get a vaccine, do your part. If you get it, you can find meaning in it. And I have patients that are living with liver cancer. It changed the way they live and why they live. And they're trying to impact their communities and inspire others. So I love, this is where I'm going to end. And hopefully we can open it for questions and the discussion. Thank you.
Thank you, Dr. Lionel, for providing us with this valuable information. It's really amazing to hear about the advancements that are happening in care and treatment, and that there's so many options available to patients now for screening. And we'd like to now open it up to the audience for any questions. So please utilize the chat box to enter your questions and comments, and our online moderators will assist with those questions. All right, well, it sounds like your presentation was spot on. We don't see any questions right now in the chat, but if you wouldn't mind hanging out with us here for a few more minutes in case any come up, we would love to pull on your expertise.
Absolutely. It was very clear. I confused everybody, but I believe hopefully it was clear enough. Thank you.
Oh, this was great. And we're seeing lots of emojis coming in through the Zoom, and we're seeing hearts and thumbs up. So you did a great job. Thank you so much. All right, I'll pass it over to Chelsea for our next portion.
Thank you so much, Manal. Thank you, Dr. Lionel. Very good information today. We'd like now at this point to bring in our community members, Mr. Derek Nelson, and Mr. Quinn Goodman. If you all could come on screen and unmute yourself. If not, we can do that for you. But we want to just take a couple of minutes just to talk to you a little bit. Welcome and thank you so much to sharing your stories. We appreciate you. So can each of you share how you were diagnosed with liver cancer and what were your initial reactions upon hearing that news? So Mr. Goodman, we can start with you.
Yeah, so I my diagnosis is it's interesting because I didn't get HCC, the one that Dr. Funko has been talking about. I have fibrolamellar carcinoma, which typically is thought as like a subset of HCC, but the more they study it, the more they understand that it acts differently. So I was in college, I was 25, and I was having some weird like abdominal pains, and I would go to the ER every few weeks, but they couldn't really find anything. And I was losing weight. I was just getting like really winded when I would try to like ride my bike to school. And so one night I had pain so bad I couldn't even lay down to sleep. And so I went to the ER again, and they did a CT scan where they didn't find a tumor, but they found a little tiny calcification. And so they came back and were like, hey, we can do a CT with contrast. And I almost turned that down because I was a poor college student, and I was like, I don't know, how much does it cost? Like $40? I don't know if I have that. But I'm glad that I did, because they did the CT with contrast, and that's when they found a big tumor. And so it was tough to get diagnosed for sure.
And
So
And-
that's kind of how I got diagnosed.
yeah, thank you so much for sharing that, Mr. Goodman. Mr. Nelson, are you able to share briefly about your diagnosis and what your initial reaction was?
Sure. Do you hear, do you hear me?
Yes, sir, we can hear you just fine. Go right ahead.
Well, I had went to the hospital for stomach pain. I went out in Ortona first. They told me it was gallstones. So they gave me medication, but it still was hurting. I was still in pain, so I went to Rochester then. And that's when I met Dr. Lionel, and he had me going through the procedures of or what they call that, when you go in that tube thing. And then he came back and said, well, you have liver cancer. I say, I said to him these words, so I'm about to die. He said, no, I have a treatment that I've been doing. And he showed me the percentage of the people that he have did this treatment with. And I said, okay, you want me to be a lab rat then, right? He said, no, don't never say that again. I'm here to help you. I'm trying to cut my camera on. Can you see me?
No, sir, not yet, but we can hear you. Go right ahead.
And he said, no, don't say that. You're not going to be a lab rat. I'm here to help you. And I said, so what are we going to do? And he gave me the procedure, what he had planned for me. He went to some other doctors, and they all put a plan for me. And hey, it came out pretty well. It came out very, very well. You know.
Wonderful. Thank you so much, Mr. Nelson. So, and just a little bit about that. So you talked about the treatment already that you and Dr. Lyle have already been working on together, which is a key point, working on this with your healthcare providers as a part of your own medical healthcare team. But Mr. Nelson, what made you feel comfortable about participating in research and in that treatment? What made you feel comfortable?
It was he looked me in my eyes. I'm a black guy. I don't go to the doctors. He looked me in my eyes. I seen the sincerity in him. They need to have more doctors like him, to be honest. I seen his sincerity saying, I'm here to help you. Nothing more than that. And hey, I say, well, let's do what we do. Let's do what you do. And it came out successful, you know.
Wonderful.
I mean, I can say I think if it had been another doctor that approached me like that, I probably wouldn't have did it. But I seen the sincerity in his eyes when he stood in my face and told me, "You have cancer, but I have a treatment that I'm working on for you, and I think you'll be the candidate for it." And I said, "Come on, let's go ahead and do it."
Wonderful. And thank you for sharing that. There were a few heart emojis and thumbs up that came into the chat. I think that that resonates very well with a lot of our attendees today. Mr. Goodman, let me bring you back into the conversation. So I heard that you mentioned your diagnosis came around when you were in school. And so we were interested in how the diagnosis impacted your education and future plans. Just what did that do for you at that time?
Yeah, it was tough because I was almost graduated. That was my last year of college. I just started the semester, and it was actually the night after the ad drop deadline for the classes was when I went to the ER and got diagnosed. And so obviously when that happened, my priorities changed, and I was like, okay, I need to, stay alive first. But I wanted to keep going to school. I wanted to move forward with the plans. But as I got more treatment, as I learned how severe the disease was, definitely changed them a lot. Kind of threw a stick in the spokes of the bike wheel, I guess. And it's still been pretty hard to deal with. That was about 2 years ago, and I've been kind of off and on, well enough and then not well enough to try and work and go to school. And so I'm on the transplant list. I'm hoping to get a transplant really soon, because I kind of see that as the way that I'll be able to participate again and be at a good baseline to go to school. Oh, you're muted.
And thank you for that. We're all pulling for you, Mr. Goodman. You know that. So we send our positive energy your way for sure. So and dealing with cancer diagnosis and undergoing treatment and being on the transplant list, those are extremely difficult experiences to have. And so, is there one, and this is for either of you to answer, Mr. Wilson, Mr. Nelson, or Mr. Goodman, is there an emotional well, I should say, how did you cope with emotional and physical challenges during during the treatment and or diagnosis? Just share maybe one way that you've coped.
Well, for me, it was positive thinking, and that's what my doctor put in me. My doctor put it was positive thinking that helped me all the way. Because even when I go see him right now, I don't even want to get. I don't even want him to give me physical. And then I say, after I go through the scans, I say to him, he said, I don't see nothing there. I say, well, I'm out of here. I'm gone. Tell me when you want me to come see you again. And he said, no, I got to check you out first. He said, I gotta check you out. I said, man, you just told me what I wanted to know. Hey, you helped me. And so I keep that positive thing. Uh, it wasn't like I came home and told my wife, I got cancer, I'm about to die. They want to do this and do that. And I didn't do that. I didn't do none of that. It's just the positive thinking that he installed in me. Because when he first told me, I said, I'm about to die. He said, he didn't say no, but he said, I have a treatment for you. I have a treatment for you. And I said, well, let's do it, man. Let's start it. We started that next week. And
Yeah,
I've been all right ever since. All right.
you
I
sure
love
are.
that man. I love that man. He
Yes,
still
sir.
ain't brought me none of that peanut butter soup, but uh I love that man. He was part of my life. He made my journey easier going
Wonderful.
through this.
Thank
More
you.
doctors need to be like him.
Thank you so much, Mr. Nelson. What about you, Mr. Goodman? How have you been able to cope? Just one strategy that you've been able to cope.
Yeah, I mean, I definitely echo Mr. Nelson. You have to keep positivity and hope as well. Because it's been really hard to stave off like depression because of all these life changes and things. And um and when you're in that dark period, um the emotional turmoil affects your physical health. Like I feel like sometimes when I had less hope, I was less compliant with treatments and keeping up the habits that I needed to, like exercising and eating well. And so keeping the emotional and mental health in check, I feel has kept me alive longer. So I would just say that. And then I've had a lot of help and support from family and friends. That's been huge, um, just to be able to rely on them. So,
Wonderful. And I just have one last question for you, for either of you. And so this is around raising awareness. So um, what would you like to see changed in terms of awareness, early detection, or research for liver cancer? Dr. Lionel has given us a lot of great information, but is there anything that you would like to see changed as it relates to awareness or early detection or research for liver cancer?
Well, what I like to see more people going in getting scanned. You know, you can be sick and not even know it until your ankles start swelling up or you can't use the bathrooms, et cetera, et cetera, et cetera. So, you know, as of right now, uh, I talks to people. I tell them what I have been through. And I say, if you're scared to go to the doctor, I'll go to the doctor with you. You know, it's just getting more people to the hospital to get scanned to see what's going on with their body. But you know, like the doctors, they very brilliant, they smart, but like a guy like me, I wouldn't understand nothing you telling me. Dr. Lionel put it in plain words where I was able to understand. And that's what's going on with a lot of people in the world today. The doctors use all these phrases and these words, and people don't know what the hell, I mean, excuse me, don't know what they're talking about. But he put it in plain words to me and made me realize what he was talking about. So I like to get more people into the office to get scanned. And if it takes me to talk to everybody I walk past with my smile and say good morning, how you doing? You know, people need that in this world today
Yes, sir.
because it's chaos out here.
Yeah.
You know, everybody is walking down the street. You go in the grocery store, everybody frowning. Why? I walk past you and say, put a smile on your face. One person say, what I got to smile about? You walk and you woke. God woke you up this morning. This is what I do daily. So I just can't be the only person wishing that. It take the world to do that, you know?
Yes, sir. And thank you so much, Mr. Nelson. Final thoughts, Mr. Goodman, take us out. What would you share?
as far as like raising awareness,
Mhm.
yeah, I don't know. It's kind of hard because I was a young college student, not even aware of most health things. I was like, oh yeah, I go to the doctor for, I don't know, like if I have a flu or something. Like I just was so unaware of a lot of the bodily functions. And so I thought it was really striking, and I didn't know this, but in Dr. Lionel's presentation about how liver cancer was projected to be like the third leading cause of death in America by 2035, I think. That's crazy. I think if more people knew that, then it would kind of help everyone realize that it's a serious thing and you got to take care of the liver. And also just like learning about the functions of the liver and how many things it does in the body.
Yeah.
I don't know. That's what I would say.
And we appreciate that. Education is so very important, education and screening. So thank you both. As we wrap up the panel discussion, I think we could talk to you all day, but we greatly appreciate you both sharing a little bit of your story, giving us guidance, and then also encouraging us to get those screenings and become more educated about liver cancer and then prevention. So we really, really appreciate that. Thank you both. So now we want to, if you have questions, you can continue to put those in the chat. And we're actually coming up on the end of the hour or the end of our time together. So by now, hopefully you started thinking about other ways that you may want to be involved with Mayo Clinic. And this is for our audience participants. So I think as Manal brings up our screen, we want to just highlight very briefly for you one of our initiatives, the Community Research Registry. And so with that registry, this gives us an opportunity to increase the representation of communities, of all communities, but particularly communities that are marginalized, to learn about studies that they're eligible to participate in. This is a national database, and it doesn't automatically enroll you in any study, but what it does is it allows you to be added to a database to learn about those Mayo Clinic studies and clinical trials and research opportunities that are available based on your profile and those that you might be interested in and those that you might have spoken with your doctor about. So if you're interested, you are more than welcome to either scan the QR code that's on the screen in the flyer, or and I'll just put it in our team chat here, and you're welcome to click on that and then complete that very brief profile questionnaire to give us some background information about your demographics and then other ways that you might be interested in learning about the studies themselves and what studies you're comfortable with being part of. Some of those are phone, some of those are focus groups, websites, and then some of them are also ones that maybe a sample or two might be involved, but you identify the type of studies that you're interested in learning about, you select that, and then once a study opportunity comes available that matches your profile, then you'll be reached out to by one of our study team coordinators. So with that said, I'm going to turn it back over to Manal. Thank you all so very much. Manal?
Wonderful. Thank you, Chelsea, for that wonderful panel discussion. And thank you, Mr. Goodman and Mr. Nelson, for sharing your journeys and being open and transparent about that journey with us. I do want to take the time to answer a couple of questions. Dr. Lionel, are you able to stay on with us for a few more minutes?
Absolutely. Yes, please.
Perfect. So it looks like we have a question about what are the main causes for liver cancer. Would you mind hitting on some of those causes for us?
Yes, I think there was a slide at the beginning of my talk where I put the different risk factors. So liver cancer usually arises from a chronic inflammation in the liver that leads to cirrhosis and eventually to liver cancer. So chronic inflammation is chronic hepatitis. Hepatitis means inflammation of the liver, and that could be from viral hepatitis B, so the hepatitis B virus infection, hepatitis C virus infection. Alcohol can also damage your liver, cause hepatitis. And then there's a class called non-alcoholic fatty liver disease or metabolic syndrome that can also cause fatty deposits in your liver, causing inflammation and eventually cirrhosis, which is damaged liver, and then that turns into cancer. So those are the big categories. But there are rarer hereditary conditions, like I mentioned, where you have deposits of iron or copper in the liver that could also cause liver cancer. There are like Mr. Goodman, there's a subtype of liver cancer called fibrolamellar HCC, as he mentioned very well. It's something we thought initially was a subtype of HCC, but as we learn more, as we characterize more, it may be its own disease entity. And patients usually develop that very early on at a younger age. It could be difficult to treat, and usually transplant is probably your best option. So I'm glad, that's being entertained for him. So that's in general, the different risk factors for that could lead to liver cancer.
Perfect, thank you. And then Dr. Cobran had a question. Is it common to have cancer from the intestines spread to the liver?
Right. And again, at the beginning of my lecture, my talk, I think I had a slide to differentiate primary liver cancer from secondary metastatic liver cancer. If you see a mass in the liver, it could be three different things. A metastasis, a spread from the colon, the small bowel, the lungs to the liver. That's actually the most common scenario. It could be bowel duct cancer, cholangiocarcinoma, that just grew from a bowel duct into and formed a mass into the liver. And then the third type is HCC, where it actually arose from the liver tissue. So yes, it's actually the most common scenario, spread from the bowels or the lungs or the colon or the pancreas to the liver. That's actually the most common scenario, but that's not liver cancer. That's a metastasis to the liver.
Sorry, I think I froze there for a second. Um, let's see. Did that conclude the answer to that question? Perfect. Okay. And then the next question we have is, what happens when the gallbladder is removed within the bile? Dr. Lionel, you're on mute, so.
Oh, sorry. Can you hear me now? Yes, so the gallbladder, unfortunately, most people don't need it. So that's why, if it starts causing issues, I usually have these gallbladder attacks is because there's an opening that will contract to push out bile into the bile ducts to help with digestion of the fat, for example. So every time you have a fatty meal, the gallbladder is going to try to contract. So when you have those gallbladder attacks, it's because it's contracting too much, it's having difficulty pushing out the bile. So that's why at certain age, most people will just have take them out because I mean that's what it does. It stores bile. But if you don't have your gallbladder, the bile that's secreted in the liver will just drain down to the bile duct and then make its way to digest the food near the stomach, the exit of the stomach. So really, most people can have their gallbladder out and still live a good life. So it's usually not a problem.
All right, and I think we have time to answer maybe one more question. I do want to note a lot of amazing comments about the presentation, the speakers, the panelists. So again, we want to extend our gratitude for your time today. Others have shared their own personal experiences with liver cancer and family members being diagnosed with cancer, and we want to thank them for sharing those experiences with us as well. So looking at the questions, this one is going to be for Mr. Goodman and Mr. Nelson. What type of support do you have in your community outside of the clinical team?
Well, for me, support, my wife is my support. You know, I live in a little small town in Minnesota, whereas I don't see many of my kind. In fact, I don't see no one of my origin. Okay, but the community has been quite supportive to me. Uh, I grew up in Chicago, and you know all about that. But this community that I live in right now has been very supportive. They uh, they knock on the door, they check on me, uh, take me fishing, and all type of stuff like that. You know, things that I have never experienced before. So I'm grateful for all that. I'm grateful for they. I mean, it's just words can't explain it for me. They've been supportive of my family. Is in other parts of states, Florida, Georgia, Illinois, that can't get to me, you know, when I'm in need or sick or something like that. So other than my wife and the people in my area, I'm grateful. I'm grateful, nothing but God flowing in people's hearts, that spirit.
Mr. Goodman, do you have any other support systems outside of your clinical team that you'd like to highlight today?
Yeah, my family as well has been huge in my ability to cope and get treated. My mom right now is my caregiver, and I mean, I always say I'd be dead if she weren't taking care of me, because there's so much behind the scenes, a lot of phone calls, a lot of insurance, mazes and um, when I've been too sick to do much at all, she's the one that handles that and cares for me, and so have my siblings and my dad too. Um, and so I feel very fortunate to have that support. It was hard for sure moving home from school because I was going to school in Utah. It was hard moving home, just leaving all my friends up there, but very much necessary. So that's what I would say.
Thank you for sharing that. Dr. Lionel, you've got a couple more questions in the chat. Do you have a couple of moments to take those?
Yes, sure.
Okay, we have one about fatty liver. How concerned should someone be if they're told that they have one?
They should be. And I think if you looked at my presentation, one of the risk factors is non-alcoholic fatty liver disease, usually as part of a metabolic syndrome. So it's very common to see patients who have diabetes who also have fatty liver disease. So if you're diagnosed with fatty liver disease, the first step is, why do you have fatty liver disease? If you have diabetes on top of that, you need to get your diabetes under control. There's a lifestyle change that should come with that, weight loss, changing your diet, and you should be screened, depending on the severity of your fatty liver disease, you should be screened for, liver cancer. So it's very important. It's not something you just say, yeah, I have fatty liver disease. No, the person who tells you that should have an action plan. And if they don't, you should demand an action plan, because that could be the one thing that leads to early detection, and if not, maybe prevents development of cancer if you can treat the cause of the fatty liver disease. So yes.
All right, last one. We are definitely over time, so we'll take this last one about what are the changes to diet that you can make, or are there any studies specifically to communities' diets and their tendency to get liver cancer?
Yeah, so I won't say that there's one diet that would cause liver cancer, or there's one diet that would prevent liver cancer. What I would say in general, you should have a healthy diet. So I think I mentioned that in my talk, kind of a balanced diet, limit the amount of red meats, more fruits, vegetables, fatty foods, processed foods, those in general are not good. Now, there's so many diets out there, keto diets, I'm not going to vouch or promote one diet, but in general, look at the content of what you're eating and limit those fatty food, processed foods, red meats. And on top of that, also exercise. Regular exercise also plays a role. And when I say exercise, regular. So even if it's 15 to 20 minutes, 3 to 4 times a week, is better than, on Sunday, 7 hours on Sunday. So the regularity also matters. So regular exercise, a healthy, balanced diet, really in the long run, especially if you have that fatty liver disease, is very important.
Okay, thank you.
Hey, Doc.
Yes.
Hey, Doc.
Yes.
You told me I had to go on a diet. I've been trying to go on a diet. I done gained 10 more pounds. I'm 250 now. And I'm just
I
eating. I'm eating less.
I think we could talk about that offline. I think your wife is partly the problem, but we could talk about it offline.
Okay, all right,
I won't expose you here, Mr. Nelson.
okay, all right.
Well, thank you everyone for the wonderful dialogue, wonderful conversation, very informative. I want to thank all of the individuals that joined us today that stuck around for the Q&A. We will have this recorded and uploaded to YouTube, so feel free to share it with your colleagues, friends, family members that might benefit from this information. And then we did post the post survey link in the chat. Let us take a couple moments to do that. It's nice to see if we increase your knowledge today. And thank you so much for joining us.
Bye.
Hi, everyone. Thank you.
Thank you.